Oh, it's been unbelievable. Despite having all these 10 different drugs that we have got approval and we are using, as we talked previously, more drugs are needed. And so one good example would be venetoclax. It's a drug that is very effective in patients who have 11-14 myeloma. So now we have a niche group of patients, around 30% sometimes in some studies, where this drug is extremely effective. In combination with Velcade, it's effective even outside of this patient population. So we're beginning to have now drugs that are being utilized and targeted for groups of subgroup of myeloma rather than a broad application. Venetoclax is also broad, but extremely in a narrow 30% of the patient population. Similarly, I think development of some of those targeted drug that may go after 414 or go after 17p deletion, 1q, they would be evolving based on the science and based on the genomics that we do, understanding how the clonal evolution takes place or heterogeneity takes place, utilizing drugs like trametinib, which is for RAS mutation, or drug like vemurafenib, which is for RAF mutation. And so we may have some mutational driven drugs that we can utilize to augment the responses with currently existing drugs. So I think there have been really great exciting developments of going after some of the targets, and I wouldn't just call them targeted drug because by themselves they may not be enough, but when they're combined with our currently existing drug, they would have great role to play in myeloma in general.